Hi guys. Yes, we are live again, guys, and this is the final session for anemia. So we'll be completing whole anemia in this session. Wait for a few seconds, and then we'll be starting. Yeah. So welcome back, guys. Welcome to the Unacademy, the largest online learning platform. Welcome. And this is the final session for anemia. Right, we'll be completing whole anemia, hemolytic anemia, thalassemia in this session, right? So, yeah, let's start. So, guys, Unacademy Learning app, you can install it for free from App Store and Play Store, and you don't have to pay. It is not a paid app, right? Yeah, and आप इसको इंस्टॉल करने के बाद you can attend live special classes and you can chat with the educator, you can ask your doubts and all of that. So it's really important, and it's amazing, right? Because you don't have to pay a single penny if you want to attend any special classes. But from now, you have to use a code for your special classes as well. Yeah, it's free, but still you have to use a code, right? And if you want to use my code, then you can use Virmani, Virmani, right? Even if you want to attend the special classes, you have to use the code. And अगर आप ये code use करना चाहो, then it's okay. And if you want to watch my special class and और अगर आप enroll कर रहे हो, then you can use any other educators code as well, right? मतलब it's not compulsory. And we are having top level of educators from AIMS, Safdarjung Hospital, and all such esteemed universities, right? And now let's discuss about the plus and iconic course. So guys, you have two choices, a plus course and an iconic course. So a plus course is um, purely Unacademy, and iconic is collaboration of Unacademy with Prep Ladder. So in plus course you get all the benefits of Unacademy, like live classes, live tests, quizzes, batch courses, structured schedule, right? But on iconic, with all these benefits, you get pre-recorded video lectures, QBank 2.0 rapid revision course, handwritten notes, and all of that. So if you are a second or third year medical student, then I would refer you iconic course. So for iconic, there are four choices: 12 month, 18 month, 24 months, and 36 months, right? And yeah, code is same with money. Then for plus, you are having many choices: 1 month, 3 months, 6 months, 12 months, 18 months, 24 months, and 36 months, right? And yeah, if you want to avail a 10% discount, then you can use code Virmani. So guys, we have started with the PathoNION series. First of all, thank you so much for your all love on Pharmac Easy series. um, yeah, we have completed almost 95% of pharmacology, and with the better understanding, and basically our motive was to understand the things rather than to cram, just uh, for the betterment of the patient, right? Because pharmacology is the base, uh, right, based of the medicine. अगर pharmacology नहीं आती then you can not study medicine and you can not write a prescription, and in future you have to write a prescription, right? You have to become a clinician, right? So that's why pharmacology is really important subject, and I thought that it was a subject जिसको सब लोग कहते थे कि इट्स ऑफ क्रैमिंग एंड आप रट लो एंड पास कर लो एग्ज़ाम एंड उससे हो जाएगा, बट नो, इट्स नॉट लाइक दैट. So we have already completed 95% of pharmacology, and thank you for all the good comments and all of your support, right, and appreciation. And now we are starting with the PathoNION series. It's a pathology companion. So we have started with the hematology, and yeah, we will be completing hematology by 6th of December, right? So yeah, yesterday हमने start करा था. Yesterday we were supposed to do anemias, but there was an emergency. I could not complete the anemia yesterday, but today here in this session we will be completing the whole anemia. Right, so let's begin. Yeah. Hypochromic anemias. Yes, yes, yes. सो गाइज येस्टरडे हमने स्टार्ट तो करा था हाइपोक्रोमिक एनीमिया, बट हम कंप्लीट नहीं कर पाए थे. सो टुडे वी विल बी कंप्लीटिंग दिस थिंग, एंड हाइपोक्रोमिक पढ़ेंगे, सिडेरोब्लास्टिक पढ़ेंगे, फिर सीधा पहुंच जाएंगे हम हीमोलिटिक एनीमियाज पर. अच्छे से डिस्कस करेंगे कि एक हीमोलिटिक एनीमिया क्या होता है, कैसे होता है, राइट? सो लेट्स स्टार्ट. Let's begin. So hypochromic anemia is the anemia that is due to the iron deficiency, and this is the commonest cause of anemia worldwide and in India, right? It is estimated that 20% of the women in the childbearing age group are iron deficient, right? ये सब हम कल डिस्कस कर चुके हैं, so we will just moving fast. While the overall prevalence in the adult male is about 2%, but in women, about 20% of women in the childbearing age or in their adulthood are iron deficient, and it is the most important, though not the sole cause of microcytic hypochromic anemia. So guys, microcytic hypochromic anemia का major cause is iron deficiency anemia. But if patient is having thalassemia, if patient is having sideroblastic anemia, if patient is having anemia of the chronic disorder, then also his PBF will show hypochromic microcytic anemia, right? So iron deficiency anemia, the commonest nutritional deficiency disorder present throughout the world is iron deficiency, but its prevalence is higher in the developing countries. The factors responsible for the iron deficiency in different populations are variable and are best understood in the context of the normal iron metabolism. So the commonest nutritional deficiency disorder, so in India also it is really very common, right, especially in the rural areas. The factors responsible for the iron deficiency is different in different populations, like deficiency भी हो सकती है, plus लॉस भी बढ़ सकता है, राइट? इनटेक कम हो सकता है, लॉस बढ़ सकता है. मेजर कॉज इज दैट. Then iron metabolism. So 1 mg of iron is lost daily from your skin, bowel, genitourinary tract. 1 mg. And a menstruating woman loses around 2 mg of iron daily. So first of all, you have to compensate this loss, as this loss is constant, right? So daily around 1 mg of the iron is lost, and in menstruating women around 2 mg of iron is lost daily. So first of all, you have to compensate this loss, right? सबसे पहले तो compensate करना पड़ेगा ये loss को. Then we will be replenishing the stores of the iron, right? So the iron required for the hemoglobin synthesis is derived from the two sources. So दो sources हैं. First of all diet है, and the second one is the reutilization of the iron that comes from the dead RBCs. Right? So your body can extract the iron from in two ways. First is diet, right? If you take leafy vegetables, beans, meat, liver, then in your diet you are giving yourself non-heme iron or heme iron, right? And then योर डेड आरबीसी के अंदर जो हीमोग्लोबिन होता है वहाँ से भी आयरन निकल जाता है, एंड दैट आयरन इज ऑल्सो रीयूटिलाइज्ड टू फॉर्म न्यूअर हीमोग्लोबिन. The average Western diet contains of the 10 to 15 mg of iron, and out of which only 5 to 10% is normally absorbed. So ideally जितना आपका lost होता है ना उतना ही absorb होगा, because your body needs to maintain its normal quantities of the iron, right? In our body we cannot have the excess amount of iron. If we are having excess amount of iron, then we might end up in hemosiderosis, hemochromatosis, and bronze diabetes, right? So if iron is more in our body, and there is some pathology that iron is not coming out of our body, then we will end up in hemochromatosis, hemosiderosis, hemochromatosis, and bronze diabetes, right? We will not go deep into these three terms, but I hope you know this, right? So our 10% of 10 mg is 1 mg only. So if 1 mg is lost, then 1 mg is only absorbed, right? And the rest 90% is again lost in the feces, and in pregnancy and in the iron deficiency states, this absorption is raised to 20 to 30%. And then iron is absorbed mainly in the duodenum and proximal jejunum, and the absorption is regulated by the mucosal block mechanism. So this mechanism we have already talked yesterday, but let me repeat it once. So this is the lumen, this is the mucous membrane, these are the cells, right? Here what will happen, iron will come from outside, it will go into the mucous membrane, right? Mucous membrane के अंदर चला जाएगा. And if your body is having excess of iron, then ये आयरन यहीं पर स्टोर हो जाएगा, अंदर नहीं जा पाएगा, राइट? But if your body is deficient of iron, then this iron will readily enter the cells and the bloodstream, right? I hope it's clear. Yeah. So just to maintain the normal quantities of iron, your body will not let excess of iron to enter your bloodstream, and that's why this mucosal block mechanism comes into place, right? So if the iron stores are low, then your iron will be readily absorbed from this. But if your iron stores are full, if you are having excess of iron in your body, then what will happen? In this mucus your iron will get stored. Iron यहाँ स्टोर रहेगा, यहीं स्टोर रहेगा आयरन, and it will stay here until the mucus sheds. जब तक ये म्यूकस मेम्ब्रेन शेड नहीं होता, आयरन यहीं रहेगा, right? And ultimately this iron will come into feces, right? I hope it's fine. Yeah. Absorption of the non-heme iron is enhanced. So देखो, as I have earlier told you that we can have iron in two forms: heme iron and non-heme iron, right? Heme iron and non-heme iron. So what is a heme iron? Heme iron is the iron that you get from the non-vegetarian sources, and non-heme iron you get from the vegetarian sources. So if you get your iron from the non-vegetarian sources, then it is readily absorbed, easily absorbed. But if you obtain your iron from non-vegetarian vegetarian sources, like green leafy vegetables and all of that, so you take up non-heme iron in that case. And non-heme iron easily absorbed नहीं होता, इसको पहले convert होना पड़ता है, right, to the ferrous form. So this is of ferric form iron, and this is a ferrous form iron. So our body needs ferrous form of iron. If you want to absorb your iron, then it should be in ferrous form, right? Our body can only absorb ferrous form of iron. So here the non-heme iron will be converted to ferrous so that it can easily absorb, right? So the absorption of the non-heme iron is enhanced by the factors such as ascorbic acid. So all the acid will increase the absorption of the non-heme iron, because if there is acidic environment, then more ferric will be converted to ferrous, and thus the absorption will be improved, right? Ascorbic acid, citric acid, amino acids, sugars, gastric secretions, HCl of the stomach, these all will increase the conversion of the non-heme iron to the heme iron. Then iron absorption is impaired by the factors like medicinal antacid, milk, pancreatic secretions, phytates, phosphates, ethylene, diamine, tetraacetic acid, and tannates. So iron absorption is impaired by the factors like medicinal antacids, milk, tea, pancreatic secretion, phytates, phosphates, ethylene, EDT or ethylene diamine tetraacetic acid. Because these all will block the conversion of the ferric to ferrous, and if your non-heme iron is in ferric form, then it is not absorbed, it cannot absorb, right? So first transport is done by DMT1, right? Non-heme iron is released as the ferrous form, right? And it is in ferric form, and it is exclusively changed to the ferrous form, and reduction of this ferric to ferrous form when required takes place as the at the intestinal brush border by ferric reductase. Intestinal brush border, right? And the transport across the membrane is accomplished by divalent metal transporter 1 DMT1. Once inside the gut cells, iron or ferric iron may be either stored or as ferritin and further transported to transferrin by two vehicle proteins, ferroportin and hephaestin. So just to take entry from the DMT1, your iron must be in ferrous form, but after entering it gets converted to the ferric form, right? And this ferric form may be stored as ferritin or further transported to the transferrin by two vehicle proteins, ferroportin and hephaestin, right? The function of the ferroportin is inversely regulated by hepcidin released from the liver and is the main iron regulating hormone, and the mechanism of the dietary heme iron absorption is not clearly understood yet, but though it is through a different transport than DMT1, but it's same as DMT1, and no one will ask you. Then transport, how the iron is transported. Till now we have discussed how it enters the mucus, how it enters the gut cells, but how the iron will come to the bloodstream, right? Let's see the live chat. Is everything going good or not? Yeah. So transport. Iron is transported in the plasma bound to a beta globulin transferrin synthesized in the liver. So it's same as albumin. A plasma protein like albumin is formed like a beta globulin and a transferrin that is synthesized in the liver. So the transferrin bound iron is made available to the marrow where the developing erythroid cells are there. So a erythroid cell will have a transferrin receptor. So a precursor of RBC will have a transferrin receptor. So this transferrin bound iron comes here, right? It attaches, then this transferrin is reutilized and iron enters the cell, right? And iron is utilized in the heme formation, right? And it may be mentioned here that transferrin receptors are present on the cells of many tissues of the body, but their number is greatest in the developing erythroblast. The transferrin is reutilized after iron is released from it. A small amount of transferrin iron is delivered to other sites such as parenchymal cells of the liver. Normally, transferrin is about 1/3 saturated, but in conditions where transferrin iron saturation is increased, parenchymal iron uptake is increased. Virtually no iron is deposited in the mononuclear phagocytic cells or RE cells from the plasma transferring iron, but instead these cells derive most of their iron from phagocytosis of the senescent red cells. And storage form of iron, that is ferritin and hemosiderin, in RE cells is normally not functional but can be readily mobilized in response to the increased demand for erythropoiesis. So the iron that is present in your RE cells will not be utilized, but if your body needs the urgent erythropoiesis or any urgent heme formation, then they can be utilized. However, conditions such as malignancy, infection, and inflammation interfere with the release of the iron from iron stores, causing ineffective erythropoiesis. Then, excretion. Our body is unable to regulate its iron content by excretion only. The amount of iron loss per day is 0.5 to 1 mg, which is independent of iron intake. Right, so if you are not taking iron, then also your body will lose around 1 mg daily. Right, even if you are not taking iron or not taking iron supplements, then also your body will lose 1 mg of iron daily. Right, so loss is constant independent of iron intake. So this loss is nearly twice more than in the menstruating woman, like I said earlier. Iron is lost from the body in both the sexes as a result of the desquamation of the epithelial cells from GI tract, from the excretion in urine and sweat, and loss via hair and nails as well. Iron excreted in the feces mainly consists of the unabsorbed iron and desquamated mucosal cells. Right? Distribution. In an adult, iron is distributed in the body as under: first is hemoglobin. Hemoglobin is present in the red blood cells, and it requires more than 65% of the need of the body iron need. Then myoglobin, it comprises a small amount of iron in the muscles, that is only 3.5%. Heme and non-heme enzymes like cytochrome, catalase, peroxidase, succeeding dehydrogenase, and flavoproteins constitute a fraction of the total body iron, 0.5%. Then transferrin bound iron circulates in the plasma and constitutes another fraction of the total body iron, 0.5%. All these forms of iron are in functional form. Ferritin and hemosiderin are the storage forms of excess iron, 30%. They are stored in the mononuclear phagocyte cells of the spleen, liver, bone marrow, and in the parenchymal cells of the liver. Right? I hope it's fine. Yeah. mm. Ah, yeah. Let's start the pathogenesis. So, iron deficiency anemia develops when the supply of the iron is inadequate for the requirement of the hemoglobin synthesis. Initially, negative iron balance is covered by mobilization from the tissue stores so as to maintain the hemoglobin synthesis. Iron deficiency anemia develops when the supply of the iron is inadequate, right? And initially, negative iron balance is covered by mobilization from the tissue stores so as to maintain the hemoglobin synthesis. It is only after the tissue stores of the iron are exhausted that the supply of iron of the marrow becomes insufficient for hemoglobin formation, and thus a state of iron deficiency anemia develops. So, first of all, if you are not having an active iron, then the stored iron will be utilized. स्टोर्ड आयरन जब खत्म हो गया तब आपकी मैरो को आयरन डेफिशिएंसी फील होगी, तब सेल्स नहीं बनेंगे, सेल्स बनेंगे तो वो माइक्रोसिटिक और हाइपोक्रोमिक बनेंगे विद लेस हीमोग्लोबिन एंड स्मॉलर इन साइज, राइट. And the development of iron deficiency depends upon one or more of the following factors. First is increased blood loss, increased requirements, inadequate dietary intake, decreased intestinal absorption. Increased blood loss, increased requirements, inadequate dietary intake, decreased intestinal absorption. Then etiology. Females in the reproductive period of life, the highest incidence of the iron deficiency anemia is in women during their reproductive years of life, and they may be from these causes like blood loss. So this is the most important cause of anemia in the woman during childbearing age. Commonly it is due to the menstrual bleeding, right. Then young girls at the onset of the menstruation may develop mild anemia due to the blood loss, and significant blood loss may occur as a result of repeated miscarriages. Inadequate intake. So in a developing country, due to lower economic status, a person cannot take so much of iron. So inadequate intake of iron is prevalent in women of lower economic status. Besides diet deficient in iron, other factors such as anorexia, impaired absorption, diminished bioavailability may act as contributory factors. Then increased requirements. During pregnancy and adolescence, the demand of the body for iron is increased, and during a normal pregnancy about 750 mg of iron may be siphoned from the mother, about 400 mg to the fetus, 150 mg to the placenta, and 200 mg is lost at parturition and lactation. If several pregnancies occur at the shorter intervals, iron deficiency anemia certainly follows. And if the patient is pregnant and if she is having anemia, iron deficiency anemia, then you should not give iron supplement in the first trimester. फर्स्ट ट्राइमेस्टर में नहीं देना आयरन आपको, राइट. You can give folic acid in the first trimester, but you cannot give iron in the first trimester because there are chances of fetal damages. Postmenopausal females. Though the physiologically demand of the iron decreases after the cessation of the menstruation, iron deficiency anemia may develop in postmenopausal women due to chronic blood loss. Following are among the important causes during these years. First is postmenopausal uterine bleeding due to carcinoma of the uterus. Second, bleeding from the alimentary tract such as due to the carcinoma of the stomach and large bowel and hiatus hernia. So postmenopausal females के अंदर what are the causes of iron deficiency anemia? So in this also the chronic blood loss is the reason. So postmenopausal uterine bleeding due to the carcinoma of the uterus, this is the main cause of anemia. Then bleeding from the alimentary canal such as carcinoma of the stomach and large bowel and hiatus hernia. So these are all the causes of the chronic bleeding, and this chronic bleeding will lead to the iron deficiency anemia because daily iron is lost and daily RBCs are also lost. So The reutilization is also not possible, plus patient is not taking iron and daily blood loss is there, so iron deficiency anemia takes place here. So adult males, it is common, it is uncommon for adult male to develop iron deficiency anemia in the presence of normal dietary content and iron absorption. The vast majority of the cases of iron deficiency anemia in adult males are due to the chronic blood loss, and the cause for chronic hemorrhage may lie at one of the following sites, such as GI tract is usual source of bleeding, which may be due to peptic ulcer, hemorrhoids, hookworm infestation, carcinoma of the stomach, large bowel, esophageal varices, hiatus hernia, chronic aspirin ingestion. Then ulcerative colitis and other causes of GIT are malabsorption and following GI surgery. Then urinary tract due to hematuria and hemoglobinuria, nose, repeated epistaxis, lungs, hemoptysis from various causes. So in the adult males, if the male is having these conditions, then only there can be iron deficiency anemia. Otherwise it is uncommon for adult male to develop iron deficiency anemia in the presence of normal dietary iron content, right? Infants and children. Iron deficiency anemia is fairly common during infancy and childhood, with the peak incidence at 1 to 2 years of age. The principal cause of anemia at this age is increased demand of iron, which is not met by inadequate intake of iron in the diet. Normal full-term infant has sufficient iron stores for the first 4 to 6 months of the life, while premature infants have inadequate reserves because iron stores from the mother are mainly laid down during the last trimester of pregnancy. Therefore, unless the infant is given supplemental feeding of iron or iron containing foods, iron deficiency anemia develops. Right? Then clinical features. First of all, anemia की वजह से the onset of the iron deficiency anemia is slow. The usual symptoms are weakness, fatigue, dyspnea on exertion, palpitations, pallor, mucous membranes and sclera, right? Pallor skin, pallor mucous membrane and pallor sclera. Then older patients may develop angina and congestive heart failure because iron deficiency anemia will increase the cardiac load as your heart needs to maintain the oxygen demand, and if your oxygen demand is high, then your heart will beat faster. And in elder patients there are generally predispositions like coronary heart artery disease, congestive heart failure and all of that. So thus older patients might develop angina and MI and congestive heart failure. Then patients may have unusual dietary cravings such as pica, जैसे कि बच्चों को होता है दीवार खाना, मिट्टी खाना, so it's pica. Pica is basically eating of chalk. So generally the patients who are having iron deficiency anemia, they would be having a craving of eating chalk. Menorrhagia is a common symptom of iron deficiency women, right? Then epithelial changes. Long-standing chronic iron deficiency anemia causes epithelial changes in some patients. The changes occur in the nails, koilonychia or spoon-shaped nails, then tongue atrophic glossitis, mouth angular stomatitis, and esophagus during dysphagia from development of the thin membranous webs, and this is called as Plummer-Vinson syndrome. Plummer-Vinson syndrome, right? Hoylenikia, atrophic glossitis, angular stomatitis, Plummer-Vinson syndrome. Now laboratory findings. So the development of the anemia progresses in 3 stages. Firstly, the storage iron depletion occurs, during which iron reserve are lost without any compromise of the iron supply for erythropoiesis. First of all, क्या है, the storage iron depleted, right? During which iron reserves are lost without any compromise of the iron supply for erythropoiesis. Then in the next stage, what will happen? Iron deficient erythropoiesis, during the erythroid iron supply is reduced without any development of the anemia. First of all, what will happen? First of all, your iron के जो stores हैं, that will be depleted, right? But जो डेली रिक्वायरमेंट है वो accomplish हो रही है, so कोई भी एनीमिया वाले सिम्टम नहीं आएंगे. सेकेंड स्टेज में क्या होता है? आयरन डेफिशिएंट एरिथ्रोपोइसिस इज देयर बिकॉज डेली रिक्वायरमेंट इज नॉट फुलफिल्ड, thus there will be development of anemia, right? Then final stage में frank iron deficiency anemia develops when the red cells become microcytic and hypochromic. The following laboratory tests can be used to assess the varying degree of iron deficiency. First is blood picture and red cell indices. So the degree of anemia varies and it is usually mild to moderate, but occasionally it may be marked in the females with the hemoglobin less than 6 gram per deciliter, due to persistent and severe blood loss. Then the salient hematological findings in these cases are as under. First is hemoglobin. The essential feature is fall in hemoglobin concentration up to variable degree, right? First diagnostic feature is hemoglobin. Hemoglobin will decrease. Then second, red cells. The red cells in the blood film are hypochromic and microcytic, and these are anisocytosis and poikilocytosis. So these are of different shapes and different sizes, and hypochromia generally precedes microcytes, right? Hypochromia is due to the poor filling of the red cells with the hemoglobin, because there is impaired formation of hemoglobin because there is deficiency of iron, right? So there will be a central pallor of red cells. So this is a RBC, and generally ये जो एरिया होता है ये इक्वल होता है, ये भी इक्वल होता है और ये भी इक्वल होता है, राइट? ए बी सी, ए इज इक्वल टू बी इज इक्वल टू सी होता है, ठीक है? बट नाउ व्हाट विल हैपन? Now centrally it will be more pallor, white, and red होगा सिर्फ पेरीफेरीज पर, राइट? देन हाइपोक्रोमिया, या आपको हाइपोक्रोमिया कैसे पता चलेगा? पीबीएफ में जब आप देखोगे देन आपको सेंट्रल पैलर बहुत ज़्यादा दिखेगा. And in severe cases there may be only thin rim of pink staining at the periphery. So there may be the chances जब आपका सिर्फ आरबीसी पे ऐसे thin pink पेरीफेरी हो और बाकी पूरा खाली हो, and that indicates that your RBC does not contain HB, right? Or it contains very low amount of HB. Then you can see target cells, elliptical forms, and polychromatic cells are often present. Then normoblasts are uncommon. RBC count is below normal, but it is generally not proportionate to fall in hemoglobin value. When iron deficiency is associated with the severe folate and vitamin B12 deficiency, a dimorphic blood picture occurs with dual population of red cells, that is macrocytic and microcytic hypochromic. Right, ड्यूअल पिक्चर दिखेगी जब यू आर हैविंग आयरन डेफिशिएंसी and a vitamin B12 deficiency. Reticulocyte count. The reticulocyte count is normal or reduced, but it may be slightly raised in the cases after hemorrhage. So hemorrhage में there would be increase in the demand, और बोन मैरो इतनी जल्दी डिमांड नहीं पूरी कर सकता, तो जो भी रेटिकुलोसाइट फॉर्म है वो ही बाहर आ जाएंगे. Fourth is absolute values of MCV, MCH and MCHC. So all these values will be decreased. MCV will be decreased, MCH will be decreased, MCHC will be decreased. Right? Then fifth, leukocytes. The total and the differential white cells count are usually normal. Right, so leukocytes are generally normal. Platelets may be normal, but they may be raised in the patient who have had a recent bleeding. So if the patient is having a bleeding, then platelets ज़्यादा, obviously it is a common sense. Then bone marrow findings. So bone marrow findings is not essential in such cases routinely, but it is done in the complicated case. Right, तो जैसे जब हम बोन मैरो एग्जामिनेशन पढ़ रहे थे, मैंने आपको बताया था कि बोन मैरो इज नॉट डन रूटीनली, बट इन द complicated cases it has to be done. Let's see the live chat, and if you are having any doubt, then you can ask me here only. So bone marrow findings. Bone marrow examination is not essential. Yeah. Then marrow cellularity. The marrow cellularity is increased due to erythroid hyperplasia. Myeloid erythroid ratio will be reduced. Right? Because erythroid is increased. Erythroid hyperplasia, as you are RBC deficient or HB deficient, so your bone marrow will try to increase this RBC, so thus there will be increased cellularity due to the erythroid hyperplasia. Then erythropoiesis. There is normoblastic erythropoiesis with predominance of the small polychromatic normoblast or micronormoblast. These normoblasts have thin rim of cytoplasm around a nucleus and a ragged and irregular cell border. The cytoplasmic maturation lags behind, so that the late normoblasts have pycnotic nucleus but persisting polychromatic cytoplasm. Right, and other cells, देखो myeloid, lymphoid and megakaryocytic cells are normal in number and morphology. Then marrow का iron. Iron staining or Prussian blue reaction on the bone marrow aspirate smears shows deficient Re iron stores and absence of the siderotic iron granules from the developing normoblast. So a marrow iron will be reduced, iron staining Prussian blue reaction is done, and on the bone marrow aspirate, and the smear shows deficient in the Re iron stores, reticuloendothelial iron stores, and there can be absence of the siderotic iron granules from the developing normoblasts, right? So ultimately iron will be reduced. Now, biochemical findings. In addition to the blood and the bone marrow examination, the following biochemical tests of value are: first is the serum iron level is low. Normal is 40 to 140 and it is often under 50, and when serum iron falls below 15 μg per deciliter, marrow iron stores are absent. So these are some important findings like TIBC, serum iron. So serum iron is low in iron deficiency anemia, and when it falls below 15 μg per deciliter, it signifies that your bone marrow has empty iron stores. TIBC, total iron binding capacity. This will increase. Why? So total iron binding capacity is increased because there is iron deficiency, and this is the binding capacity. मतलब अगर हमने थोड़ा सा भी आयरन दिया तो कितनी जल्दी वो बाइंड हो जाता है. सो दिस इज इंक्रीज बिकॉज योर बॉडी इज डेफिशिएंट एंड योर बॉडी विल बी सीइंग कि कब आयरन है और मैं पकड़ूं और उसको यूटिलाइज करूं, राइट. सो दस टोटल आयरन बाइंडिंग कैपेसिटी इज हाई and rises to give less than 10% of the saturation, and in anemia of chronic disorder, however, serum iron as well as TIBC are reduced. Then serum ferritin is very low, indicating the poor tissue iron stores. There is moderate microcytosis and hypochromia. So guys, serum iron level and serum ferritin, these things. So serum ferritin is store and serum iron is the free active iron. So serum ferritin or serum iron will be low, as you can see, right. मतलब कि ये तो कॉमन सेंस की ही बात है. प्लस बाइंडिंग कैपेसिटी इंक्रीज हो जाएगी बिकॉज आपकी बॉडी के अंदर बाइंडिंग कैपेसिटी, आपकी बॉडी के अंदर आयरन डेफिशिएंसी है, एंड जैसे ही आयरन थोड़ा सा भी आए, योर बॉडी विल ट्राई टू एक्सट्रैक्ट मोस्ट ऑफ इट, एब्जॉर्ब मोस्ट ऑफ इट, सो दैट्स व्हाई बाइंडिंग कैपेसिटी विल बी इंक्रीज. Then examination of the bone marrow aspirate showing micronormoblastic erythropoiesis, raised in iron overload and normal in anemia of chronic disorders. Then red cell protoporphyrin is very low as a result of insufficient iron supply to form heme, right. And then serum transferrin receptor proteins, which is normally present on the developing erythroid cells and reflect the total red cell mass, is raised in iron deficiency due to the release in the circulation, and normal level 4 to 9 mg per liter is as determined by amino acid. सो जो आपके प्रिकर्सर सेल्स हैं वो रिलीज होने लग जाएंगे फॉर द कॉम्पेंसेटरी चेंजेस, राइट. देन नाउ कम्स द प्रिंसिपल्स ऑफ द ट्रीटमेंट, राइट. हाउ यू कैन ट्रीट आयरन डेफिशिएंट पेशेंट. So the management of the iron deficiency anemia consists of the two essential principles. First is correction of the disorder causing the anemia, and the correction of the iron deficiency. First is correction of the disorder causing anemia, and then correction of the iron deficiency. So if there is any underlying disorder, chronic disorder that is causing anemia, so आपको वो चीज़ ठीक करवानी है. लाइक पेप्टिक अल्सर है, हाइटस हर्निया है, और एनी इसोफेजियल ब्लीडिंग हो रही है, मेलेना हो रहा है पेशेंट को. सो आफ्टर एनालाइजिंग, आफ्टर डूइंग एंडोस्कोपीज एंड ऑल ऑफ दैट, यू कैन ट्रीट द पेशेंट फर्स्ट. एंड अब आप अगर इस पेशेंट का ये अंडरलाइंग डिसऑर्डर ओके कर दोगे, देन फर्दर नो आयरन डेफिशिएंसी विल बी देयर. The underlying cause of iron deficiency is established after thorough checkup and investigations. Appropriate surgical, medical and preventive measures are instituted to correct the cause of the blood loss. Now comes the correction of the iron deficiency. The lack of iron is corrected with the iron therapy. As under oral therapy of the iron deficiency responds very effectively to the iron administration of the oral iron salts such as ferrous sulfate, ferrous fumarate, ferrous gluconate and polysaccharide iron. So the lack of the iron is corrected with the iron therapy. First of all, oral therapy of iron deficiency responds very effectively. Uh, right. Then you can also give a IV, and then these preparations have varying amount of elemental iron in each tablet ranging from 39 mg to 105 mg. Optimal absorption is obtained by giving iron fasting, but if side effect occurs like nausea, abdominal discomfort, diarrhea, iron can be given with food or by using a preparation of the lower iron content like ferrous gluconate containing 39 mg of elemental iron. Oral iron therapy continued long enough both to correct the anemia and to replenish the body iron stores. The response to the oral iron therapy is observed by the reticulocytosis, which began to appear in 3 to 4 days with a peak in about 10 days. Poor response to iron replacement may occur from various causes such as incorrect diagnosis, non-compliance, continuing blood loss, bone marrow suppression by tumor, and the chronic inflammation and malabsorption. Right? Good going, sir. All the best. First year student, from where should I start? So if you are a first year student, then you must know the classification. As in your physiology you will be doing the classification, both pathophysiology and morphology. So ये classification आपको करनी ज़रूरी है, and ये classification करने के बाद iron deficiency anemia and megaloblastic anemia is important for you. बाकी और कुछ ज़्यादा important नहीं है. Now comes the parenteral therapy. Parenteral iron therapy is indicated in the following type of cases: intolerance to the oral iron therapy, in the GI disorders such as malabsorption, then post-operative cases, then cases requiring the rapid replenishment of the iron stores, example in women with severe anemia a few weeks before expected date of delivery, right? Then let's just first revise these things जो हमने पढ़ी फटाफट से, and then we will be moving further. So हमने स्टार्ट करा था हाइपोक्रोमिक एनीमिया से. हाइपोक्रोमिक एनीमिया का मेन कॉज इज माइक्रोसिटिक हाइपोक्रोमिक एनीमिया का मेन कॉज इज आयरन डेफिशिएंसी एनीमिया, बट देयर आर अदर कॉजेज एज वेल लाइक sideroblastic anemia, thalassemia and anemia of chronic disorder. But iron deficiency anemia is commonest in India and more developing countries, right? We have talked about that our body loses around 1 mg of the daily iron, and if the woman is menstruating, then additional 1 mg loss daily is there, right? So first of all you have to replenish these or compensate these losses, and then you have to replenish the stores. So the iron required for the hemoglobin synthesis derived from the two primary sources: ingestion of the food containing iron or the senescent RBCs. So senescent RBCs are also the source of iron. Then absorption. First of all क्या होता है, आपकी सिर्फ 10% of iron is absorbed only. So if you are taking 10 mg of iron, then only 1 mg will be absorbed, because उतना ही absorb होगा जितना आपकी बॉडी ने लूज करा, right? Then in pregnancy and iron deficiency, the proportion of the absorption is raised because demand is raised, because patient is having deficiency, so binding capacity will be raised. So अगर हमें absorption नहीं करना, so it is regulated by mucosal block mechanism. How? So mucosal block mechanism. So if your body is having excessive iron, then the iron will go into the mucous membrane and वो वहाँ जाके स्टोर हो जाएगा. वहाँ जाके स्टोर होने के बाद वो वहीं रहेगा जब तक आपका म्यूकस मेम्ब्रेन शेड नहीं हो जाता. Then absorption of the non-heme iron is enhanced by the factors such as ascorbic acid, citric acid, amino acid, sugar, gastric secretions, and hydrochloric acid of the stomach. Right? Iron absorption is impaired by the factors such as medicinal antacids, milk, pancreatic secretion, phytates, phosphates, ethylene, diamine, tetraacetic acid, and tannates contained in the tea. So these all things they block the iron absorption. Like right, फिर क्या होता है? सबसे पहले तो conversion होता है right ferrous form में, because our body can only absorb iron in the ferrous form. Ferrous form में हुआ DMT1 से absorb हो गया, DMT1 से वापस से ferric form में हो गया. Now it can be stored into the ferritin and or the transferrinin by two vehicle proteins, ferroportin and hephaestin. The function of the ferroportin is inversely regulated by hepcidin, released from the liver, and is the main iron regulating hormone. And the mechanism of the dietary heme iron absorption is not clearly understood yet, but it is through DMT1. Then transport, so beta globulin और transferrin से ये transport होता है. So जो भी new erythroid cells हैं, erythroid precursors हैं, they are having transferrin receptors on which this transferrin bound iron comes and joins, and this transferrin, they leave iron, and iron comes into the RBC and get utilized, and this transferrin goes again to the bloodstream for the reutilization. Right? Excretion we have already talked about, distribution we have already talked about, pathogenesis we have already talked about, etiology भी discuss कर ली है. So etiology में हमने first of all female in reproductive life, then postmenopausal females, adult males, infants and children. Right? So ये सब discuss कर लिया है. क्लिनिकल फीचर्स भी डिस्कस कर लिए हैं, क्रोनिक चेंजेस भी डिस्कस कर लिए हैं, एनीमिया भी डिस्कस कर लिया है, लेबोरेटरी फाइंडिंग्स भी डिस्कस कर लिए हैं. राइट, सो नाउ लेट्स मूव टू द सिडेरोब्लास्टिक एनीमिया. Sideroblastic anemia. Sideroblastic anemia comprises a group of disorders of diverse etiology in which the nucleated erythroid precursors in the bone marrow show characteristic ringed sideroblast. Ringed sideroblast. Photos अभी हम देखते हैं आगे चल के. Then siderocytes and sideroblasts. Siderocytes and blasts are the erythrocytes and normoblasts respectively, which contain cytoplasmic granules of iron. So these are the erythrocytes only, but they will be having certain granules of iron. Right? Siderocytes, these are the red cell containing the granules of the non-heme iron. So these granules stain positively with the Prussian blue reaction as well as the stain with the Romanowski dyes when they are referred to as Pappenheimer bodies. So these granules are stained positively Prussian blue के साथ and Romanowski stain के साथ. And thus they are referred as Pappenheimer bodies. Siderocytes are normally not present in the human PBF, but a small number may appear following splenectomy. If patient has done splenectomy right? Splenectomy हो चुका है. A splenectomized patient will be having this sideroblastic anemia और siderocytes दिखेंगे, right? This is because the reticulocyte on release from the marrow are finally sequestrated in the spleen to become the mature red cells, and if the spleen is absent, then the final maturation steps will not take place in the peripheral blood, and hence siderocytes may appear in the blood after splenectomy, right? So siderocytes are the red cells that contain the granules of the non-heme iron. So this is a siderocyte. This is a RBC that is having a non-heme iron granule, and this is positive with the wait, Romanowski stain and Prussian blue, and इसको हम पेपेनेमा bodies कहेंगे. But this is a sideroblast, this is a ring sideroblast, this is a normal sideroblast. Ring मतलब granules जो है वो they formed a ring around this nucleus. Now sideroblast. These are the nucleated red cells or normoblast containing the siderotic granules which stain positively with the Prussian blue reaction. Siderocytes were not normoblasts. Siderocytes were reticulocytes. Or RBC that was containing non-heme iron granules. Right, depending upon the number, size and distribution of the siderotic granules, sideroblasts may be normal or abnormal. Normal sideroblasts contain a few fine scattered cytoplasmic granules representing iron which has not been utilized for the hemoglobin synthesis. These cells comprise of 30 to 50% of the normoblasts in the normal marrow but are reduced or absent in iron deficiency. अब abnormal sideroblasts are of further two types. Abnormal sideroblasts are of further two types. देखो दो टाइप के सेल्स थे. सबसे पहले हमने सिडेरोसाइट की बात करी और सिडेरोब्लास्ट की बात करी. सिडेरोसाइट की बात करी और सिडेरोब्लास्ट की बात करी. Siderocyte is normal but in splenectomy subjects. Splenectomized subject. ब्लास्ट जो है दैट इज एबनॉर्मल और उसकी एबनॉर्मेलिटी पढ़ते हैं. सो एबनॉर्मल सिडेरोब्लास्ट आर फर्दर टू टाइप्स. वन टाइप ऑफ सिडेरोब्लास्ट कंटेनिंग न्यूमरस diffusely scattered coarse cytoplasmic granules and are seen in the conditions such as dyserythropoiesis, hemolysis, and in this type there is no defect of the heme or globin synthesis, but the percentage saturation of the transferrin is increased. The other type of the ringed sideroblast in which the heme synthesis is disturbed as occurs in the sideroblastic anemias. The ringed sideroblast contain numerous large granules often forming a complete or partial ring around the nucleus. The ringed arrangement of these granules is due to the presence of the iron laden mitochondria around the nucleus. So जो one type हम जो बात करी one type इसके अंदर क्या है सिडेरोब्लास्ट है जो बहुत सारे कोर्स ग्रेन्यूल्स हैं जिसके अंदर राइट एंड it is seen in the conditions of dyserythropoiesis and hemolysis, right? But there is no defect in heme and globin synthesis, right? And the other type of the sideroblast is ringed in which heme synthesis is disturbed, राइट. हीम सिंथेसिस डिस्टर्ब हो चुका है एंड सारा का सारा जो आयरन है वो सर्कल बना चुका है अराउंड और रिंग बना चुका है अराउंड न्यूक्लियस, राइट. So this is a siderocyte, this is a normal sideroblast, and this is a ringed sideroblast, right? Siderocyte, splenectomy, normal sideroblast in the marrow, and it is normal. Right, when you are having sufficient sources of iron. Ring sideroblast is abnormal because in this heme is not formed, all the iron is here. Types of the sideroblastic anemia. First is hereditary type and second one is acquired. So hereditary sideroblastic anemia. This is a rare X-linked disorder. Rare X-linked disorder, right? Associated with the defective enzyme activity of the amino levulinic acid ALA synthase required for the heme synthesis. So, hereditary sideroblastic anemia is rare X-linked disorder associated with the defective enzyme activity of the amino levulinic acid synthase required for the heme synthesis. The affected male have moderate to marked anemia while the females are carriers of the disorder and do not develop anemia. The condition manifests in childhood or in early adult life. So, this is because of the defect in the enzyme ALA synthase that is required for the heme synthesis. Amino levulinic acid is the enzyme that is required for the heme synthesis. And in this hereditary sideroblastic anemia, this is defective. The affected males have moderate to marked anemia while the females are the carriers of the disorder and do not develop anemia. And this condition manifests in the childhood or in the early adulthood. So, as this is a X-linked disorder, so males के अंदर will be seen. Male के अंदर chromosome is XY and females के अंदर is XX, right? So as one X is there and ये X की characteristic होगी, so अगर so males में it is common, females are carriers because it is recessive. फीमेल्स के अंदर तभी हो सकता है when both are recessive traits, right? Then acquired sideroblastic anemia. This acquired sideroblastic anemia are classified into primary and secondary types. So this acquired sideroblastic anemia are classified into primary and secondary types. The primary acquired sideroblastic anemia. First of all, primary is idiopathic or refractory acquired sideroblastic anemia that occurs spontaneously in the middle-aged and older individuals of both the sexes, right? The disorder has its pathogenesis in disturbed growth and maturation of the erythroid precursors at the level of hematopoietic stem cells, possibly due to the reduced activity of the enzyme ALA synthase, right? The anemia is of moderate to the severe degree and appears insidiously. The bone marrow cells commonly show the chromosomal abnormalities, neutropenia, thrombocytopenia with associated bleeding diathesis. The spleen and the liver may be either normal or mildly enlarged, while the lymph nodes are not enlarged, right? Unlike other types of the sideroblastic anemia, this type is regarded as myelodysplastic disorder in the FAB classification, जिसके बारे में हम बाद में बात करेंगे, and thus can be pre-leukemic disorder. About 10% of the individuals with the refractory acquired sideroblastic anemia develops acute myelogenous leukemia. So secondary acquired sideroblastic anemia की बात करते हैं. So this is secondary. So it is acquired by the administration of the drugs, hematological changes, and certain inflammations. So drugs, chemicals, and toxins like isoniazid, that is an anti-tubercular drug, pyridoxine antagonist, and it is most commonly associated with the development of the sideroblastic anemia by producing the abnormalities in the pyridoxine metabolism. Other drugs occasionally causing acquired sideroblastic anemia are cycloserine, chloramphenicol, alkylating agents like cyclophosphamide, alcohol, lead. They also cause the sideroblastic anemia. All these agents cause reversible sideroblastic anemia, which usually resolve following the removal of the offending agent. Then hematological disorder. This include the myelofibrosis, polycythemia vera, acute leukemia, myeloma, lymphoma, hemolytic anemia. Miscellaneous. Occasionally, secondary sideroblastic anemia may occur in association with a variety of inflammatory, neoplastic, and autoimmune diseases such as carcinoma, mixed edema, rheumatoid arthritis, and SLE. Then laboratory findings, what you will find and how you will be confirming your provisional diagnosis. Then, so laboratory findings में sideroblastic anemias usually show the following hematological features. There is generally moderate to severe degree of anemia. The blood picture shows hypochromic anemia, like I said earlier, hypochromic microcytic, right? Absolute values MCV, MCH, MCHC are reduced in the hereditary type, but MCV is often raised in acquired type. Bone marrow examination shows erythroid hyperplasia with usual macronormoblastic erythropoiesis. Marrow iron stores are raised and pathognomic ring sideroblasts are present. Then serum ferritin levels are raised. Serum iron is usually raised with almost complete saturation of TIBC, and there is increased iron deposition in the tissues. So first is there will be moderate to severe grade of anemia, then microcytic hypochromic blood picture. Absolute values MCV, MCH, and MCHC are reduced in the hereditary type, but MCV is often raised in the acquired type. Then bone marrow examination shows the erythroid hyperplasia, with usually macronormoblastic erythropoiesis. Marrow iron stores are raised. Pathognomic ring sideroblasts are present. Serum ferritin levels are raised, right, and serum iron is usually raised with almost complete saturation on the TIBC, and there is increased in iron deposition in the tissue. So इसके अंदर serum iron will be increased, and iron बढ़ेगा तो serum ferritin भी बढ़ेगा, serum iron भी बढ़ेगा, and TIBC जो है वो कम होगा. TIBC will be decreased here, right? Then principles of the treatment, how you can treat this type of anemia. So the treatment of the secondary sideroblastic anemia is primarily focused on the removal of the offending agent like drugs, chemicals, and all of that. There is no definitive treatment available for the hereditary and idiopathic type of the sideroblastic anemia. However, pyridoxine, if you detect that there can be the effect due to its pyridoxine antagonist, then you can give pyridoxine vitamin B6 or pyridoxine routinely in all the cases of sideroblastic anemia, 200 mg per day for 2 to 3 months. Then blood transfusions and supportive therapies are indicated in all the patients. Then anemia of the chronic disorders. Pathogenesis. A number of the factors may contribute to the development of the anemia in the chronic systemic disorders, and in many conditions. The anemia is complicated by other causes such as iron, vitamin B12, folate deficiency. Then hypersplenism, renal failure is the consequent reduced erythropoietic activity and endocrine abnormalities. However, in general, two factors appear to play significant role in the pathogenesis of anemia in the chronic disorders. These are defective red cell production and reduced red cell lifespan. Right? Let's just see the live chat. उसके बाद आगे बढ़ते हैं. So first of all, defective red cell production. Though there is evidence of the storage iron in these conditions, but the amount of iron available to developing erythroid cells in the marrow is subnormal. The mononuclear phagocyte system is hyperplastic, which traps all the available free iron due to the activity of the iron binding protein lactoferrin. A defect of the transfer of the iron from the macrophages to the developing erythroid cells in the marrow leads to the reduced availability of the iron for heme synthesis despite of the adequate iron stores, elevating serum ferritin levels. The defect lies in suppression of the erythropoietin by inflammatory cytokine at some stage in erythropoiesis and hepcidin, which is the key iron regulating hormone. These inflammatory cytokines include TNF and INF beta released in the bacterial infections and tumors, and IL-1 interferon gamma released in the patients of rheumatoid arthritis and autoimmune vasculitis. Then second one is reduced red cell lifespan. Decreased survival of the circulating red cells in the chronic renal disease is attributed to hyperplastic mononuclear phagocytic system. Laboratory findings. Hemoglobin के अंदर anemia is generally mild to moderate. Hemoglobin value is less than 8. That suggests the presence of any additional contributing factors. Blood picture. The type of the anemia is in these cases is generally normocytic, normochromic, right? But may have slight microcytosis and hypochromia. Absolute values. Red cell indices indicate that in spite of normocytic normochromic anemia, MCHC is slightly low. Reticulocyte count. The reticulocyte count is generally low. And red cell survival, that is measurement of the erythrocyte survival, generally reveals mild to moderate shortening of their lifespan. Then bone marrow examination of the marrow reveals the normal erythroid maturation. However, the red cell precursors have reduced chainable iron than normal, while macrophages in the marrow usually contain increased amount of iron. Cases of iron infection often have myeloid hyperplasia and increased plasma cells. Then serum iron and TIBC. Serum iron is characteristically reduced in this group of anemias, while TIBC is low to normal in contrast to the iron deficiency, where there is reduction of the serum iron but high TIBC. Serum ferritin levels are increased in these patients and is the most distinguished feature between the true iron deficiency anemia and iron deficiency erythropoiesis in the anemia of chronic diseases. Then other plasma proteins. In addition, certain other plasma protein cause phase reactants and are raised in the patients with chronic inflammation, probably under the stimulus of the interleukin 1. उसके बाद released by the activated macrophages. These proteins include gamma globulin, C3, haptoglobulin, alpha-1 antitrypsin, fibrinogen. Then elevation of these proteins is responsible for the raised ESR commonly present in these patients. Now comes the megaloblastic anemia, जिसके अंदर पिक्चर दिखेगी macrocytic, normochromic, means cells will be large, size will be increased, but hemoglobin will be normal. Color of the RBCs will be normal जब आप PBF पे देखोगे. Megaloblastic anemia are associated with the macrocytic blood picture and the megaloblastic marrow erythropoiesis. Then this group is due to the deficiency of the vitamin B12 and folate and includes the megaloblastic picture from following two types of etiologies. First is nutritional deficiency of vitamin B12 or folate or combined deficiency, that is most common in developing countries. Then deficiency of the intrinsic factor. Deficiency of the intrinsic factor means कि there are autoantibodies मीन्स दे आर ऑटो एंटीबॉडीज जो कि आपकी बॉडी के इंट्रिंसिक फैक्टर्स पे एक्ट कर रहा है एंड इसको ब्लॉक कर रहा है. So this is a type of autoimmune disorder and causing the impaired absorption of vitamin B12, that is called as pernicious anemia, and it is rare in India but more prevalent in individuals in the European descent. Now comes the megaloblastic anemia. The megaloblastic anemia are the disorder that is caused by the impaired DNA synthesis and are characterized by a distinctive abnormality in the hematopoietic precursors in the bone marrow, and in which the maturation of the nucleus is delayed relative to the cytoplasm. Megaloblasts are both morphologically and functionally abnormal, with the result that the mature red cell formed from them and released into the peripheral blood, and also abnormal in shape, size, and most prominent abnormality being macrocytosis. The underlying defect for the asynchronous maturation of the nucleus is defective DNA synthesis due to deficiency of the vitamin B12 and folic acid. Right? राइट, इट्स फाइन. मेगैलोब्लास्टिक एनीमिया किसकी वजह से हो रहा है? इम्पेयर्ड डीएनए सिंथेसिस की वजह से. राइट, एंड ड्यू टू द डेफिशिएंसी ऑफ विटामिन B12 एंड फॉलिक एसिड, जिसकी वजह से सेल का साइज इज लार्ज. राइट. हाय रोहित, आई एम फाइन. हाउ आर यू? How are you? Less common causes are interference with the DNA synthesis by congenital and acquired abnormalities of the vitamin B12 and folic acid. So yeah, biochemistry, how vitamin B12 is utilized and metabolized and all of that. First of all, vitamin B12 or cobalamin is a complex organometallic compound having cobalt atom in center, situated within a corine ring, similar to the structure of porphyrin. Like हीम में जैसे सेंटर में आयरन होता है और आसपास में ये दिस इज अ पोरफायरिन रिंग, सेम एज इसका भी सेम होता है कोबालामिन का भी, बट सेंटर में इट इज कोबाल्ट. Right, in humans there are two metabolically active forms of cobalamin, methylcobalamin and adenosylcobalamin, which acts as coenzymes. The therapeutic vitamin B12 preparation is called as cyanocobalamin, and its sources are the only dietary source of vitamin B12 are the foods of animal protein origin such as kidney, liver, heart, muscle, fish, eggs, cheese and milk. Right. And in contrast to the foliate, fruits, vegetable containing practically no vitamin B12 unless contaminated with bacteria. Then cooking has little effect of its activity. Then vitamin B12 is synthesized in the human large bowel by microorganisms, but it is not absorbed from this site, and thus the humans are entirely dependent upon the dietary sources, and average daily requirement for vitamin B12 is 2 to 4 μg. Absorption. After ingestion, vitamin B12 in food is released and forms a stable complex with gastric R binder. R binder is a form of glycoprotein found in various secretions, example saliva, milk, gastric juice and bile, phagocytes and plasma. Right. So after ingestion, vitamin B12 in the food is released and forms a stable complex with gastric R binder. So ये समझना बहुत ही ज़्यादा इम्पॉर्टेंट है, क्योंकि अभी हमें आगे स्किलिंग्स टेस्ट पढ़ना है. स्किलिंग्स टेस्ट पढ़ने के लिए दिस इज़ वेरी मच इम्पॉर्टेंट. राइट. On entering the duodenum, the vitamin B12 R binder complex is digested, releasing the vitamin B12, which then binds to the intrinsic factor. So, first of all, vitamin B12 आया. एक second. Let me just erase this. First of all, when vitamin B12 comes, it binds to the R binder. So, vitamin B12 plus R binder complex is formed. Then this complex will further binds to the intrinsic factor, right? And if the and the intrinsic factor is a glycoprotein of the molecular weight 50,000 produced by the parietal cells of the stomach, and its secretion roughly parallels that to that of hydrochloric acid. The vitamin B12 and IF complex, on reaching to the distal ileum, binds to the specific receptors on the mucosal brush border, thereby enabling the vitamin to be absorbed, and the IF therefore acts as cell directed carrier protein similar to transferrin, and the receptor bound vitamin B12 IF complex is taken into the ileal mucosal cells. देखो अब क्या है, रिसेप्टर बाउंड वाइटामिन, जो आर बाइंडर के साथ वाइटामिन B12 बाइंड हो चुका था, इंट्रिंसिक फैक्टर के पास आया, इंट्रिंसिक फैक्टर ने वाइटामिन B12 को एक्सट्रैक्ट कर लिया और आर बाइंडर को छोड़ दिया, राइट. सो इंट्रिंसिक फैक्टर और वाइटामिन B12 दोनों साथ साथ आ गए अब, राइट. Then what will be the receptor bound vitamin B12 IF complex is taken into the ileal mucosal cells, where after several hours the IF is destroyed, the vitamin B12 released, and it is transferred to another transport protein. So जब ये इंट्रिंसिक फैक्टर के साथ बाइंड होता है, अंदर जाता है, इंट्रिंसिक फैक्टर थोड़ी देर बाद इज डिस्ट्रॉयड एंड वाइटामिन B12 इज यूटिलाइज्ड एंड फर्दर इसका सर्कुलेशन हो जाता है. सो ट्रांसपोर्ट होता है इसका. ट्रांसपोर्ट प्रोटीन क्या होता है, ट्रांसकोबालामीन 2. द वाइटामिन B12 ट्रांसकोबालामीन 2 कॉम्प्लेक्स इज फाइनली secreted into the portal circulation, from where it is taken up by the liver, bone marrow and other cells. There are two major vitamin B12 binding proteins, TC1, TC2 and a minor TC3. TC1 is not essential for vitamin B12 transport but functions primarily as a storage protein, while T3 is similar to TC2 and binds to a small amount of vitamin B12. So अब समझते हैं कि हुआ क्या, हो क्या रहा है. Wait a second. सो गाइज क्या हो रहा है यहाँ पर, वाइटामिन B12 का इंजेक्शन हुआ इन द अपर GIT, इट बाइंड्स टू द R binder, राइट, R binder प्लस वाइटामिन B12. देन दिस आर बाइंडर इसको लेकर आता है नीचे ड्यूडेनम तक, जहां पर है इंट्रिंसिक फैक्टर. देन दिस आर बाइंडर प्लस इंट्रिंसिक फैक्टर प्लस वाइटामिन B12, ये तीनों का एक कॉम्प्लेक्स बन गया. अब इंट्रिंसिक फैक्टर आर बाइंडर को बाहर निकाल देगा एंड इंट्रिंसिक फैक्टर प्लस वाइटामिन B12 इनका कॉम्प्लेक्स बना रहेगा. ये अंदर जाएंगे, इंट्रिंसिक फैक्टर डिस्ट्रॉय हो जाएगा और अंदर वाइटामिन B12 पहुंच जाएगा. नाउ दिस वाइटामिन B12 इज ट्रांसपोर्टेड बाय द ट्रांसकोबालामीन 2 एंड 3, राइट, और पोर्टल सर्कुलेशन में जाकर लीवर में, बोन मैरो में और वहां तक पहुंचा देता है. देन नाउ टिश्यू स्टोर्स. Normally, the liver is the principal storage site of vitamin B12 and stores about 2 mg of the vitamin, while the other tissues like the kidney, heart, brain together store about 2 mg. Right? Right? I hope it's fine. Normally, the liver is principal storage site of the vitamin B12 and stores about 2 mg of the vitamin, while other tissues like kidney, heart, brain together store about 2 mg. The body's stores of vitamin B12 are inadequate for 2 to 4 years. A major source of loss is via bile and shedding of the intestinal epithelium cells. A major part of the excreted vitamin B12 is reabsorbed in the ileum by the IF, resulting into the enterohepatic circulation. So tissue stores की अगर मैं बात करूँ, normally the liver is the principal storage site of the vitamin B12 and stores about 2 mg of the vitamin, while other tissues like the kidney, heart and brain, they together store 2 mg. The body stores of vitamin B12 are adequate for 2 to 4 years, and major source of loss is via bile and shedding through the intestinal epithelial cells, and a major part of the excreted vitamin B12 is reabsorbed in the ileum by the IF, resulting into the enterohepatic circulation. Right? Now, functions of the vitamin B12. Vitamin B12 plays important role in general cell metabolism, particularly essential in the normal hematopoiesis and maintenance of the integrity of the nervous system by formation of the myelin sheath. Vitamin B12 acts as a coenzyme for the two main biochemical reactions in the body. First is methylcobalamin, methyl B12, in the methylation of the homocysteine to methionine by methyl tetrahydrofolate. The homocysteine methionine reaction is closely linked to the folate metabolism. So homocysteine will be converted to methyl B12 and methyl cobalamin will be converted to methionine. When this reaction is impaired, folate metabolism is deranged and this results in the defective DNA synthesis responsible for the megaloblastic maturation. Right? Secondly, adenosylcobalamin, adenosyl vitamin B12 is propionate metabolism is, for conversion of the methyl malonyl coenzyme A to succinyl coenzyme A. So propionyl coenzyme A, methyl malonyl coenzyme A will be converted to succinyl coenzyme A, and thus इसकी वजह से ये जब इम्पेयर होता है then myelin formation नहीं होता, myelin formation is impaired. Right? Then lack of the adenosyl B12 leads to a large increase in the level of the methyl malonyl CoA and its precursor propionyl CoA. This results in the synthesis of certain fatty acids and the neuronal lipids that forms the myelin. और अगर ये deficient हो गया, abnormal हो गया, then myelin will be not formed and neurological symptoms will come. So this is the main reaction जो होता है methyl THF से. First of all, methyl vitamin B12 is needed for the conversion of the homocysteine to the methionine, and methyl THF is converted to the THF, and further it goes to the further formation of the DNA and all of that. Right? So if this is blocked, then ये सब ब्लॉक हो जाएगा. Then etiology and classification of the megaloblastic anemia. So the etiology of the megaloblastic anemia varies in three broad groups. First of all, vitamin B12 deficiency. Second is other causes. Second is folate deficiency, and third is other causes. Vitamin B12 deficiency. So deficiency of the vitamin B12 is more common due to pernicious anemia. Pernicious anemia मतलब autoimmune disorder. So the true vegetarians like traditional Indian Hindus and breastfed infants have dietary lack of vitamin B12 plus gastrectomy by lack of intrinsic factors. Then small intestinal lesions involving the distal ileum where absorption of the vitamin B12 occurs. So first of all, क्या है, true vegetarians, then breastfed infants, then gastrectomy by the lack of intrinsic factors, small intestinal lesions. What's happening outside? So these all things may cause the deficiency of the vitamin. Deficiency of the vitamin B12 takes at least 2 years to develop when the body stores are totally depleted. Right, deficiency of vitamin B12 takes at least 2 years to develop when body stores are totally depleted. Then folate deficiency. Folate deficiency is more common due to the poor dietary intake. Other causes include malabsorption in excess folate utilization, such as in pregnancy and other disease states, chronic alcoholism, excess urinary folate loss. Folate deficiency arises more rapidly than vitamin B12 since the body stores of the folate are relatively low. Which can last up to 4 months. So vitamin B12 का 2 years तक रह रहा था, but folate का only 4 months. Patients with tropical sprue are often deficient in both vitamin B12 and folate. Combined deficiency of the vitamin B12 and folate may occur from severe deficiency of the vitamin B12 because of the biochemical interrelationship with the folate metabolism. Then other causes. In addition to the deficiency of the vitamin B12 and folate, what's happening outside? Yeah, now it's fine. Other causes. In addition to the deficiency of the vitamin B12 and folate, megaloblastic anemia may occasionally be induced by other factors related to vitamin deficiency. These include many drugs which interfere with the DNA synthesis, acquired defects of hematopoietic stem cells, rarely congenital enzyme deficiencies. So there are other causes as well. So ये चीज़ हम एक बार अच्छे से ना स्किलिंग्स टेस्ट में डिस्कस करेंगे. Clinical features. Deficiency of the vitamin B12 and folate may cause following clinical manifestations which may be present singly or in combination. First is anemia, then glossitis, then neurological manifestations, and then others. Anemia. Macrocytic megaloblastic anemia is the cardinal feature of the deficiency of the vitamin B12 or folate. The onset of anemia is usually insidious and gradually progressive. Then glossitis. Typically the patient has smooth and beefy रेड टंग. आयरन के अंदर एट्रोफिक ग्लोसाइटिस थी, इसके अंदर उसके अंदर वाइट दिखेगी, प्लस इसके अंदर स्मूथ बीफी बिल्कुल रेड, एकदम रेड कलर, प्योर रेड, चेरी रेड कलर की दिखेगी एंड शाइनी. राइट. Neurological manifestations. Vitamin B12 deficiency, particularly in the patients of pernicious anemia, is associated with the significant neurological manifestations in the form of subacute combined degeneration of the spinal cord and the peripheral neuropathy, while folate deficiency may occasionally develop neuropathy only. The underlying pathological process consists of the demyelination of the peripheral nerves, spinal cord, and the cerebrum. Signs and symptoms include numbness, paresthesia, weakness, ataxia, poor finger coordination, and diminished reflexes. Others. In addition to the cardinal features mentioned above, patients may have various other symptoms. These include mild jaundice, angular stomatitis, purpura, melanin pigmentation, symptoms of malabsorption, weight loss, and anorexia. Now, laboratory findings. The investigation of a suspected case of the megaloblastic anemia are aimed at two aspects. First is general laboratory investigations of the anemia, which include blood picture, red cell indices, bone marrow findings, and biochemical tests. Special tests to establish the cause of megaloblastic anemia, जैसे कि to know whether the deficiency is due to vitamin B12 and folate, and special test is Skilling's test. So based on these principles, based on these principles, the following scheme of investigation is followed. First is general laboratory finding. So the blood picture and the red cell indices, estimation of the hemoglobin, examination of the blood film, and evaluation of the absolute values are essential preliminary investigations. First is hemoglobin. Hemoglobin will be normal. Hemoglobin estimation reveals values the normal range, and the fall in hemoglobin concentration may be of a variable degree. So hemoglobin in this will be normal, uh, and red cells morphology will be, size will be increased, macrocytes will be seen, right? Plus macrocytes are seen in hemolysis, liver disease, chronic alcoholism, hypothyroidism, aplastic anemia, myeloproliferative disorders, reticulocytosis. In addition, the blood smear demonstrate marked anisocytosis, poikilocytosis, presence of the macrovellocytes, basophilic stipplings, and occasional normoblasts may also be seen. Then reticulocyte count. Reticulocyte count is generally low to the normal in untreated cases. Absolute values क्या है इसकी, the red cell indices reveal an elevated MCV proportionate to the severity of the macrocytosis, elevated MCH, and normal or reduced MCHC. Then leukocytes, the total white blood cell count may be reduced. Presence of characteristic hypersegmented neutrophils in the blood film should raise the suspicion of the megaloblastic anemia. An occasional myelocyte may also be seen. Then platelet count may be moderately reduced in the severely anemic patients. Then bizarre forms of platelets may be seen, right? Bone marrow findings. So bone marrow cellularity will be in hypercellular bone marrow with a decreased myeloid erythroid ratio. एरिथ्रॉइड हाइपरप्लेजिया होगा जिसकी वजह से सेलुलैरिटी बढ़ेगी, सेम एज आयरन डेफिशिएंसी एनीमिया. And due to the characteristic megaloblastic erythropoiesis, megaloblasts are abnormal, large, nucleated erythroid precursors having nuclear cytoplasmic asynchrony. That is, the nuclei are less mature than the development of the cytoplasm. The nuclei are large, having fine sieve-like open chromatin that stains lightly, while the hemoglobinization of the cytoplasm proceeds normally or at a faster rate. That is, nuclear maturation lags behind the cytoplasm. So, other cells, granulocyte precursors, are also affected in some extent. Giant forms of metamyelocytes and band cells may be present in the marrow. Megakaryocytes are usually present in the normal number but may occasionally be decreased and show abnormal morphology such as hypersegmented nuclei and agranular cytoplasm. Marrow iron Prussian blue staining for iron in the marrow shows an increase in the number and the size of the iron granules in the erythroid precursors. Ring sideroblasts are however rare, and iron in the reticulum size is increased. Right? Chromosomes. Marrow cells may show variety of the random chromosomal abnormalities such as chromosome break, centromere spreading, etc. Biochemical finding. In addition to the general blood and marrow investigation and specific tests to determine the cause of the deficiency, the following biochemical abnormalities are observed in the cases of megaloblastic anemia. There is rise in serum unconjugated bilirubin and LDH as a result of ineffective erythropoiesis causing marrow cell breakdown, and the serum iron and ferritin may be normal and elevated. एंड स्पेशल टेस्ट की बात अगर हम करें तो स्टार्ट करते हैं अब एक बार स्किलिंग्स टेस्ट, देन वी विल बी डूइंग इम्यूनो एसे. स्किलिंग्स टेस्ट. सो ये क्या होता है, 24 आवर यूरिनरी एक्सक्रीशन टेस्ट होता है. स्किलिंग टेस्ट इज डन टू डिटेक्ट द विटामिन B12 डेफिशिएंसी एज वेल एज टू डिस्टिंग्विश एंड डिटेक्ट लैक ऑफ इंट्रिंसिक फैक्टर एंड मैल एब्जॉर्प्शन सिंड्रोम. सो ये क्या है, डायग्नोसिस में बहुत ज़्यादा हेल्प करता है. The results of the test are also depend upon the good renal function and proper urinary collection. Radioisotope used is 58 cobalt and 57 cobalt. Cobalt 58, cobalt 57. So सबसे पहले ये 3 स्टेजेस में काम करता है. फर्स्ट इज स्टेज 1 विदाउट इंट्रिंसिक फैक्टर. ठीक है. The patient after an overnight fasting is administered oral dose of 1 mg of the radioactive vitamin B12. At the same time, 1 mg of the unlabeled vitamin B12 is also given, right, by intramuscular route. So ये वाला हमने इसीलिए दिया था कि सारी की सारी जो टिश्यू बाइंडिंग साइट्स हैं वो replenish हो जाए. Then the patient is kept fasting for the further period of 2 hours, following which urinary excretion of the vitamin B12 is estimated. In normal individuals, 24 hours में urinary excretion would be more than 10% of the oral dose of the hot or radio labeled vitamin B12. Patients with intrinsic factor deficiency excrete lower quantity of the B12, which is further confirmed by repeating the test as in stage 2 given below. So जिसके अंदर intrinsic factor damage है, deficiency है, उनमें एब्जॉर्ब नहीं होगा तो यूरिन में कैसे आएगा, राइट. सो एब्जॉर्ब नहीं होगा तो यूरिन में कम क्वांटिटी रहेगी, फीसिस के रास्ते ही बाहर चला जाएगा. बट अब बात करते हैं स्टेज 2 विद इंट्रिंसिक फैक्टर. इफ द 24 आवर यूरिनरी एक्सक्रीशन ऑफ रेडियो लेबल्ड बाय B12 इज लो, the test is repeated using the same procedure as in the stage 1, but in addition high oral dose of intrinsic factor is administered along with the hot B12. If the 24 excretion of the radio labeled vitamin B12 is normal, the low value of the first stage of the test was due to intrinsic factor deficiency, that is pernicious anemia. Then the patients with pernicious anemia have an abnormal test even after treatment with the vitamin B12 due to IF deficiency. However, abnormal 24-hour urinary excretion of radio labeled B12 is further investigated in the stage 3 for the cause of intestinal malabsorption. So stage 3, test for malabsorption. So vitamin B12 in some patient absorb vitamin B12 in water as was stipulated in the original Skilling's test. Modified Skilling test employs the use of protein bound vitamin B12, and in conditions causing malabsorption the test is repeated after the course of treatment with antibiotics and anti-inflammatory drugs, right. So हमने इसको एक बार अच्छे से देख लिया है. देखते हैं स्टेज 1, स्टेज 2, स्टेज 3. स्टेज 1 में है इंट्रिंसिक फैक्टर की डेफिशिएंसी, स्टेज 2 में है इंट्रिंसिक फैक्टर इंटैक्ट, स्टेज 3 में है मैल एब्जॉर्प्शन सिंड्रोम. स्टेज 1 के अंदर इंट्रिंसिक फैक्टर की डेफिशिएंसी है तो यूरिन के अंदर क्वांटिटी विल बी लेस, फीसिस के अंदर वो सारा का सारा निकल जाएगा, राइट. फीसिस में निकल जाएगा. देन इंट्रिंसिक फैक्टर इंटैक्ट है तो नॉर्मल वैल्यूज आएंगी. मैल एब्जॉर्प्शन में है तो वो एब्जॉर्ब नहीं होगा, 10 लेस होगा यूरिन में. बट इसके बाद एंटीबायोटिक्स देंगे, एंटी इन्फ्लेमेटरी ड्रग्स देंगे और फिर से ये टेस्ट करेंगे ताकि ये रूल आउट कर सकें. Now serum enzyme levels. Besides killing test, another way of distinguishing whether the megaloblastic anemia is due to cobalamin or folate is by serum determination of the methyl malonic acid and homocysteine by sophisticated enzymatic assays. Both are elevated in cobalamin deficiency, while in folate deficiency there is no only elevation of the homocysteine. मिथाइल मैलोनिक एसिड ये दोनों राइज होते हैं विटामिन B12 की डेफिशिएंसी में, एंड ओनली होमोसिस्टीन राइज इन फोलेट डेफिशिएंसी, राइट. नाउ vitamin B12 assay. So microbiological assay and radio assay. Microbiological assay. In this test, the serum sample is to be assayed is added to a medium containing all other essential growth factors required for a vitamin B12 dependent microorganisms. The medium along with the organisms is incubated and the amount of the vitamin B12 is determined turbimetrically, which is then compared with the growth produced by a known amount of the vitamin B12. Several organisms have been used for this test, such as Euglena, Gracilis, Lactobacillus leishmania, E. coli, Escherichia coli, and Onchronos. Right, E. gracilis is or Euglena is used, however, because it is more sensitive and accurate. The addition of the antibiotics to the test interferes with the growth and yields false low result. Then radio assay of the serum B12 is by radioisotope dilution or RID, and radioimmunoassay RIA have been developed. These tests are more sensitive and have the advantage over microbiological assays in that they are simpler, more rapid, and the results are unaffected by antibiotics and other drugs which may affect the living organisms. So, test for the folate deficiency. How we will diagnose a folate deficiency? The normal range of the serum folate is 6 to 18 Ng per ml. Values of 4 Ng per ml or less are generally considered to be diagnostic of folate deficiency. Measurement of the FIGLU urinary excretion or formiminoglutamate acid urinary excretion after histidine load was used formerly for assessing the folate status, but it is less specific and less sensitive than the serum assays. Currently, there are three tests used to detect the folate deficiency. First is urinary excretion of FIGLU or formiminoglutamate acid, then serum and red cell folate assay. First is urinary excretion. Urinary excretion of FIGLU. Folic acid is required for the conversion of the FIGLU to glutamic acid, right, in the catabolism of the histidine. So thus, on oral administration of the histidine, the urinary excretion of the FIGLU is increased in the folate deficiency is present, if the folate deficiency is present. Then serum folate assay. The folate is in serum can be estimated by two methods, microbiological and radio assay. Microbiological assay, this test is based on the principle that the serum folate acid activity is mainly due to the presence of the folic acid coenzymes 5-methyl-THF, and that this compound is required for growth of the microorganism Lactobacillus casei. Then the growth of the L casei is inhibited by addition of the antibiotics. Radio assay कैसे होता है? The principle and the method of the radio assay by the radioisotope dilution test are similar to that of the serum B12 assay. The test employs labeled pteroyl glutamic acid and methyl THF. Commercial kits are available which permit the simultaneous assay of both vitamin B12 and folate, right? So red cell folate assay, red cell contains 20 to 50 times more folate than in the serum. Thus red cell folate assay is more reliable indicator of the tissue stores of folate than the serum folate assay. Microbiological radioassay and protein binding assay method can be used for estimation of the red cell folate. Red cell folate values are decreased in patients with megaloblastic anemia as well as patients with pernicious anemia. So red cell folate assay. Red cells contain 20 to 50 times more folate than the serum. Thus red cell folate assay is more reliable indicator of the tissue stores of folate than serum folate assay. Microbiological assay and protein binding assay method can be used for estimation of red cell folate. Red cell folate values are decreased in the patients with megaloblastic anemia as well as in the patients with pernicious anemia. Then what is the principle of treatment? How we can treat the patient of megaloblastic anemia? Most cases में megaloblastic anemia need the therapy with the appropriate vitamin which includes hydroxycobalamin as a IM injection 100 mg for 3 weeks and oral folic acid 5 mg tablet daily for 4 months. Severely anemic patients in whom a definite deficiency of either vitamin or cannot be established with certainly are treated with both vitamins concurrently. Then blood transfusion should be avoided since it may cause circulatory overload. Packed cells may however be infused slowly. Treatment of megaloblastic anemia is quite gratifying. Marrow begins to revert back to normal morphology within a few hours of initiating the treatment, and becomes normoblastic within 48 hours of start of the treatment. Reticulocytosis appears within 4 to 5 days after the therapy is started and peaks at the day 7. Then hemoglobin should rise by 2 to 3 gram per deciliter each fortnight. The peripheral neuropathy may show some improvement, but subacute combined degeneration of spinal cord is irreversible. Right? Then pernicious anemia. So guys, pernicious anemia is same as megaloblastic anemia, but in this it is autoimmune. Pernicious anemia was first described by Addison, so it is somewhere regarded as pernicious and Addison's anemia, and as a chronic disorder of the middle-aged and elderly individual of either sex in which intrinsic factor secretion ceases owing to atrophy of the gastric mucosa. The condition is therefore also termed as Addisonian megaloblastic anemia. The average age of the presentation is 60 years, but rarely it can be seen in the children under 10 years of age as well, and that is regarded as juvenile pernicious anemia. Pernicious anemia is seen most frequently in the individuals in North European descent and African Americans, and is uncommon in South Europeans and Orientals. Then pathogenesis. There is evidence to suggest that the atrophy of the gastric mucosa in PA results in the absence or low level of IF and is caused by autoimmune reaction against the gastric parietal cells. The evidences in support of the immunological abnormalities in the pernicious anemia are as under. The incidence of the PA is high in the patient with other autoimmune diseases such as Graves' disease, myxedema, thyroiditis, vitiligo, diabetes, idiopathic diabetes, and idiopathic adrenocortical insufficiency. Patients with PA have abnormal circulating autoantibodies such as anti-parietal cell antibody 90% of the cases and anti-intrinsic factor antibody, that is 50% of the cases. So both cases में parietal cell के खिलाफ भी अगर auto antibodies हैं, then also pernicious anemia होगा, and intrinsic factor के अगर against हैं auto antibodies these, then also pernicious anemia होगा. बट 90% केसेस के अंदर पैराइटल सेल्स के अगेंस्ट होता है, एंड 50% ऑफ द केसेस के अंदर इंट्रिंसिक फैक्टर. Relatives of the patients with PA have increased incidence of the disease or increased presence of the autoantibodies. Then corticosteroids have been reported to be beneficial in curing the disease both pathologically and clinically. Then pernicious anemia is more common in the patients with A-gamma globulinemia, supporting the role of cellular immune system in the destruction of the parietal cells, and certain HLA types have been reported to be associated with the PA. Then morphological features. The most characteristic pathological finding in the PA is gastric atrophy affecting the acid and the pepsin secreting portion of the stomach and sparing the antrum. Gastric epithelium may show cellular atypia. About 2 to 3% of the cases of the pernicious anemia develop carcinoma of the stomach, and other pathological conditions are secondary to the vitamin B12 deficiency and include megaloblastoid alterations in the gastric and intestinal epithelium and neurological abnormalities such as peripheral neuropathy and spinal cord damage. Clinical features. The disease is insidious in onset and progressive slowly, and सबसे पहले anemia, glossitis, neurological abnormalities, neuropathy, subacute combined degeneration of the spinal cord, but this is irreversible. Reticuloverbal neuritis, GI manifestations, diarrhea, anorexia, weight loss, dyspepsia, hepatosplenomegaly, congestive heart failure, hemorrhage manifestations, and other autoimmune diseases such as autoimmune thyroiditis may be associated. Right? And then principles of the treatment. Parenteral vitamin B12 replacement therapy. Parenteral, you have to give parenteral therapy. अगर आप orally दोगे then same problem रहेगी. because absorption में problem है. Symptomatic and supportive therapy such as physiotherapy for neurological deficits and occasionally blood transfusion. Follow-up for early detection of cancer of the stomach. Most of the abnormalities due to the vitamin B12 deficiency can be corrected except the irreversible damage of the spinal cord. Spinal cord एक बार damage हो गई then नहीं हो सकती वो reverse. Corticosteroid therapy can improve the gastric lesion with the return of the acid secretion, but high incidence of the gastric polyp and cancer of the stomach in these patients can only be detected by frequent follow-ups. And yeah, with this let's end this session, and in the next session we'll be doing hemolytic anemias. In the next session of anemia we'll be doing hemolytic anemia, thalassemia and aplastic anemia. Right, so let's end the session here, and bye guys, take care, stay healthy, stay safe, stay positive, and we'll be meeting soon. Bye, take care.